I think it would be most appropriate to begin by thanking Aggie so much for what she's been able to do and what she continues to do. I'm particularly happy to see such a large crowd, such a big number of patients, families, and others. I think this may very well be the largest group that we've ever had for one of these symposia. I am a surgeon, and I'm going to talk to you about the surgical management of pancreatic cancer in 2014. And I'll begin, as so many people do, with a few words about the epidemiology of the disease, its frequency, and how serious a problem it really is, although I think everybody here understands that. This year, 2014, we expect that there will be well over 46,000 new cases of the disease in the United States. And the sad truth of it is that still the majority of patients who have pancreatic cancer will die. So almost 40,000 deaths in this year associated with that diagnosis. California, because it has about 10% of the population of the United States, ends up accounting for about 10% of the deaths. Over 4,000 people will die in California from pancreatic cancer. Bill has already mentioned that it is currently the fourth most common cancer killer. Turns out that it's the second most common gastrointestinal cancer killer, and he's already showed you this slide, which, as a result of the fact that the incidence of pancreatic cancer is increasing by about 1% a year, means that in the next 10 years or so, pancreatic cancer will become the second most common cause of cancer deaths in this country. Now let me go into a little bit more of the details that are important epidemiologically and important to patients who come to a physician or a surgeon hoping that something can be done. Unfortunately, about 85%, the vast majority of new cases of pancreatic cancer are already advanced by the time the diagnosis has been made. They may either be locally advanced, in which case they are termed stage 3, and often the problem with the local advancement of the disease is that some of the big blood vessels near the tumor have already become involved by the tumor. I'll show you a little bit more about that in a few moments. The majority of patients, though, have what is termed stage 4 disease, and that is the way we describe it when the tumor is actually disseminated, spread more distantly outside of where the pancreas is to the liver, most commonly, occasionally to the lungs. And generally speaking, we do not remove the cancer surgically in patients who have either stage 4 disease and in most patients who have stage 3 disease. There may be some exceptions in patients with stage 3 disease, and we'll talk about that in a little bit. So it's not surprising from what I've said, this is a different way of saying the same thing, that the majority of people who present with the disease have either stage 3 or 4 disease. And the patients who, if you're going to get the disease to begin with, you would hope would have early stage, really do represent the minority. Stage 1 and 2 represent probably no more than about 17 or 18% of all of the patients. Another important series of facts, observations, have to do with the fact that patients present with later stage disease, obviously, it's intuitive to imagine this, are not going to live as long. And this slide shows the median survival, the actual survival for the majority of patients with stage 3 disease and stage 4 disease. The two bars on the right-hand side of this table have median survivals that are actually less than a year. What's interesting, and I think depressing as well, is that even though we describe patients with stage 1 and 2 disease as having early disease, fact is that even those patients where we're saying early disease is present don't have early disease. Their tumors are disseminated as well. And the proof of that is the fact that the median survival for patients with stage 1 and stage 2 disease is still less than 2 years. And the reason for that is that they have microscopic disease that isn't apparent at the time that the diagnosis is made, but that eventually progresses and eventually these patients pass away from that, from those metastatic deposits. So to just summarize very briefly, if patients have either stage 3 disease where the major blood vessels are involved, or if they have distant metastatic disease, stage 4 disease, generally speaking, surgery is not an option. There may be some exceptions in patients with stage 3 disease. We'll come back to that in a little bit. So let me give you a little bit of an anatomy lesson. The liver is the big organ at the top of the page, and it occupies a good bit of the upper part of the abdomen. This right side of the liver is on the right side of the abdomen. The left lobe extends over to the left side. This is the gallbladder. The bile ducts are the green structures that you see here. The food that we eat, the liquid that we drink, moves down the esophagus and enters the stomach, which is this organ, and eventually is passed out of the stomach into the beginning of the small intestine. This part is the duodenum, and then the small intestine goes down here, and generally most of it is not shown. This is the pancreas, and much of it is behind the stomach, and so I've outlined it in yellow just so that it's more apparent to you. This gets the stomach out of the way and I think makes things a little bit more clear in terms of the pancreas and the structures that surround it. The other picture did not show the spleen, which is this organ here that sits out toward the so-called tail of the pancreas. We actually describe the pancreas arbitrarily as this part being the so-called head of the pancreas. This part here, which overlies these big blood vessels, is called the neck. We call this part the body of the pancreas, and as I've already said, this part is the tail. Now, let's talk about where these tumors can develop and talk a little bit about what we do for patients if they have early stage so-called resectable disease. So this tumor that I've shown you in this slide occurs in the body or in the tail of the pancreas. Most of pancreatic cancers don't occur in the body or the tail, but some certainly do. And when they do, and when they are localized to this area, as I've shown in this picture, they are termed resectable, which means that we can operate, surgeon can operate, take out the part of the pancreas that has the tumor in it, and hopefully cure the patient. The majority of pancreatic cancers, however, occur in the head of the pancreas. And this shows a a tumor located squarely in the middle of the head of the pancreas. Even if it grows and gets larger, which I've shown by this image, this still is viewed as being a localized cancer as long as it hasn't spread to involve some other structures. And it too is a resectable tumor. Surgeon can take it out. Now, what I've just described to you are stage 1 and stage 2 tumors. Let me describe next so-called stage 3 tumors where some of the blood vessels can be involved. This tumor in this slide is right near some of the major blood vessels, and as it grows, it has the potential to actually involve this big blue structure here, a vein, this smaller arterial structure here, and under these circumstances, where the cancer may involve what's called the portal vein or the hepatic artery, the story is different. This is stage 3 disease, and it's viewed as being unresectable. Surgeons would not remove this. Or the tumor can also be in the head, as the previous one was, but located in a little bit of a different spot down here, and as it grows, it could involve these other blood vessels that you see down in this area. If that happens, and the tumor involves either the superior mesenteric vein, which is the blue structure, or the superior mesenteric artery, which is the red structure just next to it, again, it's unresectable. So these are two examples of what we would call vascular involvement, blood vessel involvement, that make the tumor stage 3 and unresectable. We're going to come back to some of those kinds of tumors, stage 3 tumors, in a little bit. But let me go on and talk to you about the stage 1 and the stage 2 tumors and what kind of surgery could be done, is done, in an effort to get these tumors out. They really fall into two categories. One, which is applied to the tumors that are in the body or the tail of the pancreas, is called a distal pancreatectomy. And the other, which I think everybody has heard of, is the so-called Whipple operation, which is the kind of operation that we do for tumors that are in the head of the pancreas. The big name, which all of us, even if we are surgeons, try not to say, is pancreaticoduodenectomy. At any rate, let's go back to this localized cancer in the tail of the pancreas, which is resectable. What do you do? How do you get this out? What do you have to remove? Well, it's actually pretty simple. The dotted line is where the surgeon cuts. And what you end up removing when you cut across the pancreas enough away from where the actual tumor is so that you get it all out, you remove what I've shown here. You remove the tumor, you remove the pancreas in which it's growing, and you remove the spleen. Why do you remove the spleen? Patients will sometimes ask me about that. And the reason is that for tumors in the body or the tail of the pancreas, when they spread, they will often spread along these blood vessels into this part of the spleen, which we call the hilum of the spleen. And obviously, the goal is to remove all of the all of the tumor. So you want to take the spleen out too in case the tumor has spread to that part. So what you have left when the spleen and that part of the pancreas is removed is the remaining pancreas, which is more than enough to do all of the things that the pancreas needs to do. And you put, you sew closed, you sew shut the part of the pancreas that you have cut across. So that's a distal pancreatectomy. Let me talk to you next about the Whipple operation. And there really are two kinds of Whipple operations that we do. The first is what has become known as the standard Whipple operation. And it was the first Whipple operation that Dr. Whipple, and that's where the name comes from, performed. And these were done to a considerable extent in the mid-20th century. So in the late 1940s and early 1950s is really when this operation first started to be done. So the standard Whipple, as it's shown here, again with the dashed or the dotted lines, removes the gallbladder. This is the liver, remember. It removes the gallbladder. It removes much, but not all, of the bile duct here. It removes about a third of the stomach. It removes all of the duodenum and the beginning of the small intestine here. And of course, it removes the head of the pancreas, and this is supposed to be the tumor that's sitting in the head. The cut across the pancreas goes along the line that I described a little bit ago as the neck of the pancreas. So here's how you put things back together. It's not the only way to do it, but it's a way that works quite well and is often used. So you take what's left of the pancreas and you attach it to the small intestine there. You take what's been cut across here at the bile duct and you attach it to what's the ongoing small intestine after the pancreas has been attached. And then a little way further down, you connect the stomach to the intestine. So patients, once they've recovered, can eat and drink, and the food goes into the stomach, and it eventually leaves the stomach and enters the small intestine, just like it did before, but obviously it's a different connection. And while that's going on, the pancreas is secreting the things that it normally secretes, which it's secreting into the intestine through the new opening. The bile is being secreted from the liver, and it's going in as well. And these mix, and they go down the stream here and eventually mix with the food. And I think Dr. Roth, who will be talking in a little bit, may have some things to say about some of the problems that people experience if the mixing of the food with the bile and the pancreatic juice isn't as efficient and as adequate as it is before this operation. So now the Pylorus-preserving Whipple, which I've heard described recently as a mini Whipple. And I said I didn't really know what that meant, and they explained that this is what they were referring to. So the difference between the two operations, the Pylorus-preserving Whipple and the standard one, really has only to do with the fact that we don't remove any of the stomach. And so you can see that the whole stomach is in place, and this area here is the so-called pylorus. I didn't point out to you in the original slide that I described the anatomy on that the pylorus is in this area. The pylorus is a muscular ring which opens and closes, and many people think that it's important in order to allow the stomach to empty whatever there is in it gradually rather than more rapidly. Maybe true, maybe not. At any rate, the cure rate of the cancer is the same, regardless of which of these two operations you do. And most of us, most surgeons all over the world, because the cure rate is the same and because we generally don't want to take out anything we don't have to, do the pylorus-preserving operation. Now let me tell you a little bit about the history of the Whipple operation. And I must tell you that when I was in training, learning to be a surgeon, this was generally viewed as the most difficult, and I would say probably the most dangerous general surgical operation that anybody would ever attempt. So it has that history, the most difficult operation to do. And again, years ago, the mortality rate, that is the number of people who would die just from having the operation, forget the reason that it was being done, forget the cancer for a moment, the operation itself had a mortality rate of about 25%. If you didn't die from the operation, the frequency of complications was very, very high as well. And if the patient didn't die from the operation, and if the complications were taken care of, the quality of life of the patients who survived was miserable. And so, because almost no one in those years was cured, it was very reasonable to ask the question, why do it at all? And some very, very thoughtful, intelligent surgeons and others asked that question. Well, there's a reason why we do it today. And the first is that the mortality rate from the operation, for a variety of reasons, has gone down a tremendous amount, to the point where in most centers it's in the neighborhood of 1 or 2%. If it's substantially higher than that, it ought not to be done in those places. And at UCLA, we've been, I guess you have been fortunate in that the mortality rate is actually less than 0.5%. So it's very, very good. Complications continue to occur. And this is an area that surgeons and others are trying to work on as well. But we get almost everybody over the complications. They are better managed than they used to. The quality of life of patients once they recover from the operation tends to be pretty good, although again, Dr. Roth is going to talk to you about some of the things that may not be so good in some of the patients. And as Dr. Go mentioned, the cure rates are really pretty substantial, although there's no question that we have a long way to go before we get to where we want to be in terms of who we cure. The one overarching reason, I suppose, that most people think that the Whipple operation will have a place for years and years to come, for the foreseeable future, is, as best we know, cure of this disease is not possible without it. The 5-year survival rates really vary a lot from institution to institution, and I'm showing you here some of the best institutions in the country which have cure rates that have been published that vary between 12 and 23%. I'm proud to say, although I'm not quite sure why it's true, that UCLA really looks pretty good when you compare it, although I'm not sure there really are statistically significant differences from institution to institution. Now I'll say a word or two about adjuvant therapy, treatment, chemotherapy primarily, given after the operation. And for pancreatic cancer, it doesn't make any difference whether the operation is a distal pancreatectomy or a Whipple operation. It's the disease that is the issue, and this is an effort, this adjuvant therapy, which virtually everyone is recommended to have, is an effort to kill any microscopic tumor that might be left behind. All patients virtually all patients should have that. And I won't say anything more. We have a distinguished speaker, Dr. Rosen, who's going to tell us much more about that a little bit later on in the program. Okay, so I've been promising for several minutes now that we were going to come back to the patients with so-called stage 3 disease, where the cancer may involve one or another of the major blood vessels, the superior mesenteric vein or artery, or the ones up above, which we have viewed as unresectable. And I think that the first point to address is something that many of my patients will ask me in the office when I'm seeing them for the first time, and I tell them that I think operation is not the thing to do. Rather, I think that because the blood vessels are involved, another approach is a better one. And they'll say to me, why not resect the blood vessels? Surgeons are supposed to be able to do that. And it's true. Surgeons can resect blood vessels, no doubt about it. But it's a different reason. It's a deeper, more complex reason than we don't want to resect the blood vessels, or it's too dangerous to resect the blood vessels. The answer is on this slide, and it is that patients who have stage 3 disease, where the blood vessels are involved, we know from experience, and I don't just mean UCLA knows, I mean pancreatic specialists, surgeons, and others all over the world know that in patients with stage 3 disease, even though you can't see it, they have microscopic spread elsewhere. Almost always it would be to the liver. And as I've indicated, you can't see it. You can't see it on an MRI scan. You can't see it on a CT scan. But experience tells us that it's there. And if we resect stage 3 tumors, even though we know how to resect a segment of the blood vessel, the cancer is going to come back. And obviously that's not what this is all about. That's not what we're trying to accomplish. So what do? We say, no, we're not going to operate on you first, which typically we would do in patients with early stage disease. Instead, we recommend that you get chemotherapy for a good long time, at least 6 months, and I've certainly had patients where we've gone longer than that, up to a year. We try to kill, by giving the chemotherapy, we try to kill the microscopic tumor that's in the liver or God knows where, somewhere intra-abdominally in most cases, with the chemotherapy. And then we reevaluate the patient. We watch on repeated CT scans whether there's evidence that the tumor is shrinking. We reevaluate them with blood marker. Many of you may have heard of CA19-9. That's a pretty reliable one to follow in these circumstances. And resection surgery, a Whipple operation, becomes possible in some of these patients who are being treated that way. We actually were the first group to report this, an article that goes back to 1998. And the first patient I did this on, I think was in 1991. So it's got a rather long history, and a number of other people at different institutions are doing this as well in more recent years. This is a picture, a CT scan, a before and after, of one of the very first patients we did. And I want to point out to you that this is the pancreatic tumor, and this other little circular thing here is the superior mesenteric vein. And you can see how the tumor looks on the image as though it's grown into the vein. There's really no obvious separation between the two. And after about 6 months of treatment, you can see that the tumor has gotten smaller, and that where there was contact before, there is now here a suggestion that there isn't contact. So we were very excited about that. and operated on this particular patient and did in fact remove the tumor. The result of that over a number of years is that we now have a number of long-term survivors. More than 20 who have survived between 5 and 17 years after the operation. And if you calculate a survival rate for that particular group, it's about 28%. We have 8 more patients who are really coming very close to the 5-year mark, which is obviously an artificial mark, but nevertheless, if you add those 8 more to the 20 plus that we already have, this would be a 5-year survival rate of over 50%. Very highly selected group of patients, but nevertheless, if you're the patient, you're the patient's family, it's very meaningful. So this is my last slide, and it's an effort to sort of summarize for you where we are in 2014. Haven't really shown you new operations, and I think that it's fair to say that further major advances in terms of changing this or that way we do the operation are not likely to be made at all. The major change that's occurred over the years is that the safety of the operation has increased extraordinarily to where, as I've said, the likelihood of dying as a result of having the operation is less than 1%. Maybe a more optimistic way of saying that is that the likelihood of surviving is well over 99%. But obviously, we're saying the same thing. So changes in technique are not likely to increase the survival. Rather, I think that for more patients to be cured of this disease, what's really going to make the difference, almost certainly, are more effective drug treatments, more effective chemotherapy agents, and other sorts of agents of which you hear something new on the horizon every couple of months. So I think it's a very, very exciting time and reason to be optimistic. And an optimistic note is a good note to end on. Thank you.